Dr. Mohanty, Dr. Keshika, Dr. Asim Parikh sir, and organizers for giving me an opportunity here. After having discussing the fixation modalities, we'll just go briefly into the types. This is Cecil Roraback classification. It includes the integrity of the prosthesis. That means whether it is type 1, obviously it's non-displaced, type 2 is displaced component, type 3 where you would consider a replacement option where it is displaced and the component is loose. And the SU classification involves the epiphyseal segment length. Here type 2 just reaches the anterior flange and type 3 goes distal to the anterior flange. Here it's more likely that the prosthesis is going to be loose. So these are the cases where the fixation may not work or it may have high rate of failure. So when Roraback 3, SU 3 failed previous fixation, you don't want to keep on doing the fixations again. There are many times there are non-unions following previously fixed periprosthetic fracture, and relative indication of elderly patient who need to get up and about early, and you want to offer a definitive surgery to these patients. There are predictors. The patient has probably fallen because of some sort of instability. That means the knee was not functioning very well, or there was some functional element, there was mechanical axis deviation or some loosening. That means obviously this is an indication for revision and not for fixation again. So roughly, if you have to put in a nutshell, the more proximal fractures are amenable for fixation, and the distal ones, especially those beyond the flange, are for revision surgery. We have already discussed this. When it is loose prosthesis, it's replacement, and there are problems of the fixation. There are high rates of non-unions, delayed unions, there are reoperation, knee stiffness, there are malunions, and this malunion would not be tolerated well with the prosthesis there inside. And these are elderly patients. You have to have delayed weight bearing in such patients where you are refixing. And let's consider the criteria by Kane, and the goals of treatment as defined by Kane are absence of knee pain, fracture union at 6 months, range of movement at least 90 degrees, and return to normal ambulatory status. And these are the factors which we have already discussed. The age of the patient, age of the implant, whether it is a primary or revision surgery, medical comorbidities, osteoporosis, RA are the factors which would favor replacement prosthesis, bone loss and comminution, and implant condition. History, clinical examination and CT scan would tell you many times so-called well-fixed fixation, and you can find that prosthesis is loose. Many times on the AP X-ray, if there is a widened intercondylar distance, it will give a clue that it is not just simple fracture, but it is sort of a TY type of fracture. And the revision can be with revision components, stamped femoral prosthesis, or constrained, or some sort of a constrained prosthesis, either linked or non-linked constraint, and then distal femoral replacement. So there are 3 different kinds of prosthesis that we can do. So if we have to put in when we are dealing with unstable component, with a good bone stock, it can be a revision orthoplasty. If it's a poor bone stock, then it's a mega prosthesis. And there was another option, but it has got a high failure, which is called a APC, or allograft prosthetic composite, which is allograft are not available in India. So just there's a nice paper by Gann which compares the tumor prosthesis and locking plate fixation, and the significant differences between the mean time of weight bearing. The patients with the prosthesis were up and about in just 3 days time, whereas locking plate group, you could not make them weight bear for at least 18 weeks. So this difference was statistically significant. The complication rates were in both the groups were equal, but what requires to be seen, you have to read between the lines, and this is a classification of complication by Clavian and Dindu. So there are grades of classification, which are minor complications and severe complications. So tumor process had just grade 2, that is minor complications, where a lock plate had grade 3B, that means they had deep infections, septic non-unions, needing reoperation, and many times with the dual plates, a lot of dissection, they had stiffness of the knee. So just I will go through the examples. 78-year-old lady, total knee replacement was done 6 months back. She fell down and had supracondylar fracture. This was a picture, and the surgeon tried to fix it through a separate lateral approach. It was so comminuted that no fixation was possible, and he chose to give a cast to that lady for 6 weeks. Now we had central midline incision, and there was another incision, which is a railroad on the lateral side. They were well healed, and they were separated by 7 centimeters. The lateral incision was a posterolateral curving anteriorly distally. So when we decided to do a distal femur replacement, we took the same posterolateral incision for the blood supply selection, and this was what we got: totally comminuted distal fragment along with the prosthesis came out in hand, and it was a distal femur comminuted. We did a poly block and a distal femur replacement using a endo model rotating hinge. So it looks like this somewhat. Yeah, this is a poly block. So on X-ray it looks like it is a radiolucent. This is a cheaper option. You can have a metal which is a Mega C option, which is slightly costly, which works the same in this elderly lady. Another example, 74-year-old lady, she had diabetic, chronic liver disease, had bilateral total knee replacement. The left one was done in 2012, right one was in 2010, but immediately after the surgery she had some sort of a cellulitis infection. She had to undergo fasciotomy, and this was in 2012, and she underwent 2-stage revision in 2012, and she presented in 2017 like this. So obviously this prosthesis was loose, and here no fixation is possible. However, distal femur replacement was not needed. You could it was the fracture was slightly more proximal. There was loss. This was a skin condition. However, the serological markers for the infection were negative, and the prosthesis was loose. There was a defect in the femur, F3A defect, and a tibia T3A defect. So both MCL was jeopardized on the tibial side, and LCL was jeopardized on the femoral side. This was the condition. So we used the poly block, and this was managed with the endoclinic hinge. It was not a rotating distal femur replacement, but just the rotating hinge with the poly block or augments there. Okay, thank you.